The aim of this research was to examine specific family rejecting reactions to sexual orientation and gender expression during adolescence as predictors of current health problems in a sample of lesbian, gay, and bisexual, so LGB young adults. What this means is this paper wants to identify whether higher rates of family rejection are associated with poorer health outcomes for the people identifying themselves as LGB and which specific reactions are associated with their child's sexual orientation and health problems in emerging adulthood. The social determinants covered in this paper are identified as lack of social support and coping skills, social status, childhood experiences, physical experiences, biology and genetic endowment, sexuality, gender, because men were more likely to experience rejection, culture, because it may be the culture of the parents explaining why they are rejecting, and experiences of discrimination. The main health inequalities identified in this paper are relating to mental health outcomes such as depression and attempted suicide, substance abuse, HIV, and sexually transmitted disease risk due to unprotected sex, as well as adolescent pregnancy. Other health inequalities can be a result of culture, as some races and ethnicities have differences in level of family support, and they have been found as well in this paper. So, Latino men reported the highest number of negative family reactions to their sexual orientation in adolescence. This is a health inequality as it's not the individual's choice what race they're born into and therefore cannot be treated the same as other races that may be more accepting. Gender is also the causation of a health inequality here as men reported more rejecting reactions than women. Minority stress is also a health inequality, so experiencing and internalizing negative life events and victimization in social environments. This has negative health outcomes in the LGB community, including depressive symptoms, substance abuse, and suicidal ideation. Also, parents and caregivers play a vital role in an adolescent's health and well-being, so it's not just about the feelings of rejection that an individual may feel, but also what they are missing out on from having a central and positive role model. This is another health inequality that can be drawn from this paper. Whilst the health inequalities can be worked on and we can attempt to lessen the gap and make it more equitable for LGB people, the biological inequality cannot be changed, and therefore it is important to recognise this as such. This makes the health inequalities somewhat impossible to avoid. Many other population-based studies have reported high levels of negative health outcomes for LGB adults compared with heterosexuals, so this health inequality definitely exists, not just in the findings of this report alone. The results of this study show that negative family reactions to an adolescent's sexual orientation are associated with negative health problems in LGB young adults. Fewer health differences were observed when moderate levels of rejection were compared with low rejection. LGB young adults who reported higher levels of family rejection during adolescence were 8.4 times more likely to report having attempted suicide, 5.9 times more likely to report high levels of depression, 3.4 times more likely to report illegal drug use, and 3.4 times more likely to report having engaged in unprotected sex compared with peers from families with no or low levels of family rejection. It also identifies Latino, gay, and bisexual men as a subgroup that's particularly affected, with higher levels of family rejection and higher rates of negative mental health and HIV risk outcomes. Statistically significant observations on gender alone also indicated that men reported more rejecting reactions than women. Some of the key A health disparity identified in this paper is the mental health outcomes already identified, and a way to explain this relationship between adverse health and LGBT communities is minority stress. So the minority stress model helps explain the wide-ranging health disparities that exist among people in sexual minorities. So compared with heterosexual individuals, homosexual people suffer from greater mental health problems, including substance abuse disorders, affective disorders, and suicide. So the minority stress theory helps unfold this high prevalence of mental health disorders as a result of the stigma, prejudice, and discrimination, creating a stressful social environment in people who belong to stigmatized minority groups. So also according to the minority stress model, sexual minority groups experience unique and chronic stresses such as victimization and internalized homophobia, which as a result have deleterious impacts on mental health. So it is these stresses that then lead to substance abuse as a way to cope. So substance use and abuse can be conceptualized as methods to regulate or avoid negative effect and to reduce tension. In terms, there are some limitations to this study. So this is a retrospective study that measures young adults' reported experiences that occurred several years earlier, which can pose some issues with recalling the wrong information, otherwise known as recall bias. To overcome this, the study was designed in such a way that the questions were directly about particular events as opposed to how rejecting their parents were generally. So the authors of the study did well there to reduce instance of recall bias. The paper also asked people between the age of 21 and 25, but according to data, people are most likely to come out to their family at the age of 19. So perhaps to avoid recall bias further and have the results a little more accurate, they could have made the starting age a little bit earlier. The nature of a retrospective study is also that there's no control over whether all information has been collected as required. This paper also only concerned a relatively small population of the LGB community in one urban geographic area, which may have its own external contributing factors to why these families reject their child's sexual orientation, such as community pressure or lack of exposure to other ways and views. This paper also did not include any individuals that were neither Latino or white. Since this paper has a section where it assessed the role of ethnicity, it should have included greater ethnic diversity in order to assess the potential disparities. In order to establish clearer links amongst minority groups that have not been previously studied or have little understanding on links between social disparity and health outcomes, a study should generally involve a much larger sample size than 224 people. The paper also did not establish causation of why there is rejection or why there are negative health outcomes, which would be vital in order to plan health promotion going forward. Volunteer bias is also present in this paper, so this is basically referring to the idea that the participants are not representative of all possible participants. So the young adults who express interest in this research differed from those who do not or cannot consent to this research, making this a bias. Overall, the paper and study was designed well to. There was no plan put forward to address the results or any mention of a health promotion campaign to address this issue, merely just recommendations. However, they mentioned they'd done some preliminary work with families who are ambivalent and conflicted about their children's LGBT identity and indicated that the families are receptive and interested to learn about how their words, actions, and behaviours affect their child's health. The paper mentioned additional work is needed to demonstrate how to help families increase support for their LGBT children and made some recommendations mentioned in the next slide involving the expansion of pediatric practice to encompass assessment of family relationships and behaviours, as helping families identify and reduce specific rejecting behaviours is integral to helping prevent mental health problems for LGBT young adults. So the author's recommendations that are listed on this page are targeted at paediatric providers as they can help decrease family rejection and increase support for LGBT young people in several ways. So counselling families, providing anticipatory guidance and referring families for counselling and support can help make a critical difference in decreasing risk and increasing wellbeing for many LGBT youth who have limited support. However, I still think additional work is needed on top of these recommendations listed. These recommendations are a great start as they not only target increasing awareness amongst parents and caregivers, but they also address support for LGBT individuals. However, I would make two other suggestions. So one, ensuring that LGBT individuals are not facing rejection in other areas of their life too, such as in school, as rejection from families are not the only groups that these people face. So the Australian Human Rights Commission reported that schools that implement protective policies for LGBT individuals mean these individuals are 50% less likely to be physically abused and have mental health conditions, including attempting suicide. Whilst family rejection is clearly a key contributor to the health outcomes, ensuring that they are not further rejected in other settings, such as their schooling setting, is equally as important and should be addressed. And two, understanding what the reasons are why acceptance is a problem, I think, is extremely important. So the process of sexual orientation disclosure in families may be shaped by the values and cultures of the family. So for instance, families with a strong emphasis on traditional values and religion, marriage, emphasis on having children, may be less accepting of sexual minority orientation than less traditional families. Parental responses to youth's disclosure of sexual minority orientation may also differ based on race and ethnicity. So it's extremely important to acknowledge why the rejection Health professionals would be able to utilize these results once they fully understand the facts behind the LGBT community, social inequalities, and health outcomes and those links. Anti-homophobia training and LGBT specific education should also be required for healthcare professionals, but also people in other settings, so schools, welfare, housing, and other social agencies, also in the legal system. This will develop a cultural awareness of sexuality minorities and enable more responsive service provision at a primary healthcare level. There's also an urgent need for LGBT research within the Australian context and more statistics so that we can better understand this minority group and how to help. This particular research paper is tremendously valuable, not just to those who treat LGBT youth medically, but also for those who interact with these individuals legally. So I certainly hope that this information is translated to attorneys and others involved in the juvenile justice system so that support and acceptance is not just in the home, but also evident in the justice and legal systems, but also so that bias, discrimination, and judgment is taken out of any proceedings. So it's also, it's extremely important that no practitioners or welfare workers, etc., blame minority groups for their choices, whether that be lifestyle or dietary, as a result of not truly understanding their risk of disease, because it's extremely important to understand that someone's health outcomes are not always in their control and they cannot be blamed for their lifestyle and dietary choices.